everyone. This is Dr. Simran from Vijayawada Hospital, Mumbai. Thanking you very much for giving this wonderful opportunity to speak over here. So this is about the utility of bedside echocardiography in neonates with meconium aspiration syndrome with PPHN. So we all know meconium aspiration syndrome is associated with persistent pulmonary hypertension and is a serious and commonly encountered respiratory distress in neonate. Around 1/5 of the mass patients go on to develop PPHN with a high mortality of 11.1% as compared to neonate of mass without PPHN. 2D echocardiography is useful but not routinely performed in most of our Indian neonatal units due to equipment or skill constraint. So, with the objective to establish the targeted neonatal echocardiography, help us in correlating clinical and hemodynamic parameters in neonate with mass with suspected PPHN, and also to facilitate longitudinal real-time assessment and proper further management plan for these babies in the form of vasodilators and or diuretics. So this was a prospective observational study conducted in NICU of Tertiary Care Hospital in Mumbai over a span of 9 months. So there were total 100 of patients, neonate of mass, who were evaluated clinically and echocardiographically for the diagnosis of PPHN. These echos were performed by NICU TN echo trainees using portable sonocyte ultrasound machine with S12 probe after 6 months of experience, which were supervised and reviewed by pediatric cardiology consultant. Based on this echocardiographic assessment, patients were categorized as mass with PPHN and mass without PPHN. The first cohort of mass with PPHN were further graded into mild, moderate, and severe variety based on the parameters of tricuspid regurgitation, shunt flows across the PFO, ASD, or PDA, and septal position. Further, serial echocardiography analysis were done to see the response of the treatment in this cohort of mass with PPHN. So this is the apical four-chamber view. The first image showing the moderate TRZ and the second image showing the severe TRZ. This is the subcostal view in the first image showing the right to left direction shunting of across the ASD PFO, and in the second image we can see that there is bidirectional flow across the ASD. The first diagram in this slide reveals the left to right shunting across the PDA and the corresponding Doppler report. In the second, apart from the left to right shunt, we can see that there is transient systolic right to left shunt occurs in this PDA. And in the third diagram, we can see that there is right to left shunt across the PDA. Normally, the IVS, that is interventricular septum, bulges into RV. However, when there is a moderate PS, the IVS becomes flattens out, and with the severe PS, the IVS bulges into LV. Echocardiographic evaluation was also taught for further guidance in the fluid and diuretic therapy. So when these 100 patients were evaluated clinically, based on pre versus postductal saturation difference of more than 10%, hypoxemia on blood gas, tachycardia, tachypnea, etc. Out of these 100 patients, 28 were categorized as PPHN. Whereas when the similar patient of 100 neonate did underwent echo-based analysis, the PPHN diagnosis jumped from 28 to 47%. Both this cohort, that is mass with PPHN and without PPHN, were evaluated for the requirement of high flow oxygen and ventilatory requirement, and the analysis revealed a significant high number of the oxygen flow and ventilatory requirement in cohort of mass with PPHN. Various grading of the PPHN, that is mild, moderate, severe, were done at admission and following the serial echocardiographic directed therapy, and after the therapy, the grading were evaluated. So at admission, there were 6 cases of mild, 15 moderate and severe, and which after the therapy had come down in the moderate category to 6 and in the severe to 9. IV sildenafil, milrinone and Lasix were evaluated for their final impact on the outcome, and it was found to be none of this drug has been having any impact on the final outcome. So out of 47 patients of the PPHN, 9 patients had died, and out of 53 patients without PPHN, 5% had died. So echo-based pickup of PPHN was 47% as compared to mere clinical-based PPHN, which was found in only 28% of the patients, that is neonate admitted with mass. PPHN grading were found to be in 41% pre-therapy, and after serially guided echocardiographically directed therapy, this data had come down to 15%, which was statistically significant. HFOB and ventilatory requirement was seen comparatively higher in cohort of mass with PPHN. Medical management was escalated or decreased based on the serial echo findings. there was no statistical difference among the patient treated with various vasodilators and diuretics. So to conclude, PPHN and mass-associated PPHN is a common cause of increased mortality amongst neonates. 2D echo is an important, non-invasive and a bedside tool to diagnose this subclinical PPHN in neonates with mass and correlates substantially with the clinical severity. Serial bedside TN echo also facilitates a comprehensive point of care management of neonate with mass with PPHN and thus helps decrease the associated morbidity and mortality. And coming to the last, TN echo training for a proposed period of time within the NICU will empower the trainees fellows to promptly perform bedside 2D echo for management of neonate of mass and aiding to better final outcome. Thank you.